Acute confusional state, delirium. 1. Definition. Acute confusional state equals delirium equals acute organic brain syndrome. Affects up to 30% of elderly hospitalized patients. 2. Predisposing factors. Mnemonic, aged FP. Age greater than 65 years. Geriatric dementia, background of dementia. Elderly with injury, e.g. hip fracture. Debility, frailty or multimorbidity. Frequent drugs, polypharmacy. Pre-existing vulnerabilities. 3. Precipitating events. Mnemonic, MRCP. Infection, especially UTI. Metabolic, e.g. hypercalcemia, hypo/hyperglycemia, dehydration. Change in environment. Heart-lung neuroendocrine issues, any major illness. Alcohol withdrawal. Pain, severe. Stool stuck, constipation. Comorbidities, exacerbation. 4. Features. Mnemonic, MADM obvious. Memory loss, short-term long-term. Agitation or apathy, very agitated or withdrawn. Disorientation. Mood changes. Observed hallucinations, visual. Vigilance low, poor attention. Sleep cycle disturbed. 5. Management. Mnemonic, Team Halo. Treat underlying cause, infection, metabolic, etc. Environmental modification, familiar staff, reduce noise, clocks, light. Avoid unnecessary medications. Medications, if needed. If NO Parkinson's haloperidol 0.5 mg first line. 2010 NICE haloperidol or olanzapine, note olanzapine now not recommended. If Parkinson's. First line equals lorazepam, if urgent. Or atypical antipsychotics quetiapine, clozapine. Consider reducing Parkinson meds. Alzheimer's disease, management. 1. Overview. Alzheimer's disease equals progressive degenerative brain disease. Most common cause of dementia in the UK. 2. Non-pharmacological management. Mnemonic, care activities. Cognitive stimulation therapy for mild to moderate Alzheimer's, NICE recommended. Activities to promote well-being, tailored to personal preferences. Reminiscing sessions, group reminiscence therapy. Enhancement via cognitive rehabilitation. Think, cognitive care. 3. Pharmacological management. Mnemonic, DGR, memory defense. 8. Mild to moderate Alzheimer's. Donepezil. Galantamine. Rivastigmine. These are acetylcholinesterase inhibitors. Remember, DGR helps with memory grip in early stages. B-memantine, NMDA receptor antagonist. Mnemonic, MMM, memantine for moderate and more severe cases. 4. Used in M1, moderate disease if ACHE inhibitors are not tolerated. M2, moderate to severe add-on to ACHE inhibitors. M3, severe disease monotherapy. 4. Managing non-cognitive symptoms. Mnemonic, danger for what not to do. Don't use antidepressants for mild to moderate depression in dementia. Antipsychotics only if risk of harm to self/others. Agitation, hallucinations, or delusions causing severe distress. Use caution. Antipsychotics are a last resort. 5. Donepezil specifics. Mnemonic, done equals down plus dreamless. Down relatively contraindicated in bradycardia, slows the heart. Dreamless side effect, insomnia. Alzheimer's disease, pathophysiology. 1. Overview. Alzheimer's disease, AD, equals progressive, degenerative brain disease. Most common cause of dementia in the UK. 2. Risk factors. Mnemonic, AFA milli decades. Age, increasing age. family history of AD. Mutations, autosomal dominant inheritance, 5% cases. Amyloid precursor protein, CHR21. Presenilin 1, CHR14. Presenilin 2, CHR1. Down syndrome. E4 allele of APO, cholesterol transport protein. Caucasian ethnicity. Autosomal dominant inheritance. Degenerative family forms. Decades reminds you this is a disease of aging and degeneration. 3. Pathological changes. Macroscopic changes. Mnemonic, CH atrophy. Cortex atrophy. Hippocampus atrophy. Widespread cerebral atrophy, mainly cortex plus hippocampus. B. Microscopic changes. Mnemonic, AB tornado, like tornado. A beta plaques, A beta, equals extracellular cortical plaques from amyloid deposition. Tau tangles equals intraneuronal neurofibrillary tangles. Hyperphosphorylated tau impairs function tangle formation. C. Biochemical changes. Mnemonic, ACH decline. Acetylcholine, ACH, deficit. Due to damage in ascending forebrain cholinergic pathways. 4. Neurofibrillary tangles. Mnemonic, tangled tubules. Tau protein equals binds tubulin stabilizes microtubules. In AD, tau becomes hyperphosphorylated. Leads to paired helical filaments. Microtubule stability lost disrupts neuronal transport. Forms neurofibrillary tangles. Think of tau as the tracks of a train. Hyperphosphorylation derails the system. Delirium versus dementia. Focus, factors favoring delirium. Mnemonic, a fifth ad, like the football body FIFA plus D for delirium. Think, delirium strikes suddenly like a FIFA red card, abrupt, confusing, and dramatic. 1. Acute onset. Sudden change, often over hours to days. 2. Fluctuation of symptoms. Symptoms worsen at night, sundowning. Periods of normality in between confusion. 3. Impairment of consciousness. Reduced alertness, clouded awareness. Not typically seen in dementia. 4. Fear and agitation. Patient may appear distressed, anxious, or restless. 5. Abnormal perception. Includes illusions and visual hallucinations. 6. Delusions. Often paranoid or bizarre beliefs, e.g. thinking people are trying to harm them. Quick summary. If the patient presents with a fifth ad acute, fluctuating, impaired consciousness, fearful, abnormal perceptions, delusions, think delirium, not dementia. Dementia, causes. 1. Common causes. Mnemonic, a very likely dementia, ABLD. Alzheimer's disease. V. Vascular dementia, multi-infarct, 10 to 20%. L. Lewy body dementia, 10 to 20%. Think, these are the big three of dementia. 2. Rarer causes, is almost equal to 5%. Mnemonic, HCP-HIV. H. Huntington's disease. C. CJD, Creutzfeldt-Jakob disease. P. Pick's disease, frontal and temporal lobe atrophy. HIV, dementia in 50% of AIDS patients. Think, rare but HCPs, healthcare professionals, should spot HIV-related dementia. 3. Important differentials, potentially treatable. Mnemonic, dementia reversible causes. D. Depression. E. Endocrine, hypothyroidism, Addison's. M. Malnutrition, B12, folate, thiamine deficiencies. E. ETOH in drugs, alcohol, barbiturates. N. Normal pressure hydrocephalus. T. Tumor, brain tumor. I. Infection, syphilis. Accident, subdural hematoma. Dementia reminds you that not all dementia is permanent, some causes are reversible. Frontotemporal lobar degeneration, FTLD. 1. Overview. FTLD equals third most common cortical dementia after Alzheimer's and Lewy body dementia. Group of disorders with early onset, behavioral changes, and language disturbance. 2. 3 recognized types of FTLD. Mnemonic, FBS think, FTLD people speak differently. F. Frontotemporal dementia, Pick's disease. P. Progressive non-fluent aphasia, aka chronic progressive aphasia, CPA. S. Semantic dementia. 3. Common features of FTLD. Mnemonic, firm personality. F. 40-ish onset, before age 65. I. Insidious onset. R. Relatively preserved memory and visuospatial skills. M. Marked personality and social conduct changes. For Pick's disease, most common FTLD subtype. Mnemonic, pick me. P. Personality change. I. Increased appetite, hyperorality. C. Conduct problems, disinhibition. K. Knife blade atrophy, focal gyral atrophy. M. Microscopic findings. Pick bodies, tau protein inclusions, silver staining. Gliosis. Neurofibrillary tangles. Senile plaques. E. External appearance, frontal and temporal lobe atrophy, macroscopic. 5. Management of FTLD. Nice, do not recommend ACHE inhibitors or memantine for frontotemporal dementia. Why? Because cholinergic systems are less affected compared to Alzheimer's. 6. Progressive non-fluent aphasia, CPA. Key features, short and struggling speech. Non-fluent, agrammatic speech, short, effortful sentences. Comprehension preserved. 7. Semantic dementia. Mnemonic, fluent but fuzzy. Fluent speech, but empty content, words lack meaning. Recent memory better than remote, opposite of Alzheimer's. Lewy body dementia. Mnemonic, Lewy equals. L. Lucid moments fluctuate. E. Early hallucinations. W. Wobbly walk, Parkinsonism. Y. Your attention plus executive function go first, before memory. 1. Overview. Accounts for up to 20% of dementia cases. Pathological hallmark, Lewy bodies equals alpha-synuclein cytoplasmic inclusions. Found in substantia nigra, paralimbic, and neocortical areas. Up to 40% of Alzheimer's patients have Lewy bodies too. 2. Relationship with Parkinson's disease. Mnemonic, 1-year rule. If dementia occurs before or within 1 year of Parkinsonism, think Lewy body dementia. If motor symptoms precede dementia by more than 1 year, it's Parkinson's disease dementia. 3. Clinical features. Mnemonic, flick PV, like a flickering presentation. F. Fluctuating cognition. L. Lewy body pathology. I. Impairment in attention and executive function, earlier than memory issues. C. Cognitive decline, progressive. K. Key contrast, hallucinations plus early attention deficits is not equal to Alzheimer's. P. Parkinsonism, rigidity, bradykinesia. V. Visual hallucinations, often vivid. Also, may see delusions or non-visual hallucinations. 4. Diagnosis. Clinical diagnosis is common. SPECT, DIT scan, using 123-IFBCIT is increasingly used. Sensitivity is almost equal to 90%, specificity is almost equal to 100%. 5. Management. Mnemonic, don't touch neuroleptics. Acetylcholinesterase inhibitors, e.g. donepezil, rivastigmine, and memantine may be used. Avoid antipsychotics, neuroleptics. Patients are very sensitive. May cause irreversible worsening of Parkinsonism. Often a question clue, deterioration after starting antipsychotic.